I don't know how many of you were there, back when some of the original anti-TNF data was being presented at the ACR, but I think it was the word out there was that people were doing these trials with the anti-TNFs, and I think there was enormous skepticism at that time that blocking a single molecule would do anything for rheumatoid arthritis, because there are so many of these pro-inflammatory molecules that are being produced. So this is sort of an outline of what we'll go over. The first part is really to talk about what the rationale was for those first trials, because there was a rationale that they used to get the company to let them go ahead with that. So just to remind people that rheumatoid arthritis is a classic autoimmune disease. I mean, we now have a very good autoantibody associated with it. There's a lot of evidence for both type 3 hypersensitivity, which is immune complex hypersensitivity, and type 4 hypersensitivity, which is T-cell mediated. That's not true in all of the inflammatory arthritises. Some of them are pretty much pure immune complex, and some are pretty much pure T-cell mediated, but rheumatoid arthritis is both. Feldman was in the lab, and his group was looking at synovial tissue. They would get samples and they would deaggregate it, and then they would put it into tissue culture and they would study the production of cytokines. And what they had been doing is looking to see, if you block one cytokine, what happens to the rest. And so they had data that they published back in the late 1980s, early 1990s, that if you block anti-TNF in these synovial cultures, human synovial cultures, that you could block IL-1 production, and you could also block production of GM-CSF, and they've looked at other ones as well. So they came up with this model of rheumatoid arthritis where TNF was thought to be, according to them, the key molecule, and then you would have downstream of it, you would have all of these other pro-inflammatory and anti-inflammatory molecules. And it was really, it was a disturbance of the cytokine balance. And so if you tip that balance away from pro-inflammatory, homeostasis would occur and you would get rid of the inflammation. So he apparently had somebody in his lab who went to industry, to Senecor, where they were looking at an anti-TNF initially for sepsis, and apparently this fellow was able to convince them to actually do a trial in rheumatoid arthritis, and this is the very first treatment of rheumatoid arthritis patients with what eventually became Remicade. And their outcome measures there weren't very well developed. They had the number of swollen joints and the CRP, and this was an open trial, basically, and a single dose. And they gave 20 milligrams per kilogram of anti-TNF in an open trial, and these were the results. And you can see that the joint swelling, the count of swollen joints, and even more dramatically, the CRP dramatically decreased, but of course this was not controlled, so the next they had to do a double-blind placebo-controlled trial, and this was it. This was the first trial. They tried two different doses, 1 milligram per kilogram and 10 milligrams per kilogram as a single dose, and their outcome was something new, a composite index called the POLIS score that was a little bit like our ACR 20, but they had slightly different criteria, but the idea was you had to improve X amount by in at least 4 of the parameters to get a 20% for a POLIS 20, 50% for a POLIS 50, and this is what happened. These are actually the numerical scores at POLIS 20 and POLIS 50 with the different amounts of drug. It's easier to see down here below where they just take out a few of the parameters and look at tender joints or swollen joints. So this is after one injection, and they got this decrease in tender joints and swollen joints. So pretty much with that one trial, they knew they had a winner. So they did do some science with this. In addition to the in vitro studies that they'd done before, they said, well, what's going on here? How are these anti-TNFs, how is anti-TNF working? And they said, well, if you've got inflammation here, if you've got something stimulating macrophages, they make cytokines like TNF, and that recruits leukocytes to that area. And so we should see a decrease in leukocyte migration if this is all true. And so this was their study. They did labeled peripheral blood neutrophils and then did a gamma candrin. This was before and after their treatment with rituximab, and I think everybody could probably convince themselves that they really did affect leukocyte migration and prevent leukocytes from migrating into the joint. So just to back up a little bit in terms of the pathophysiology of rheumatoid arthritis, we mentioned it was both a type 3 and a type 4 hypersensitivity disease. So Nathan Zweifler, who had a beautiful review in 1973 about rheumatoid arthritis and particularly emphasized the immune complex aspects of this, had this great, he refers to some article that I couldn't get a copy of, but they took IgG from the serum of patients with rheumatoid arthritis and injected the IgG into a joint that was not inflamed to see what would happen. And the control was, IgG from a normal individual. And what they found is that, if you inject serum from a rheumatoid patient into a joint, you get inflammation in that joint. And you don't get that with a IgG from a normal individual. And you can actually, people more recently have done this with animals, of course. They'll take a mouse that is immunodeficient, that doesn't have any T cells or B cells, so it doesn't respond to the human IgG. You can inject, and it also has a mutation so that its cells are more likely to respond to immune complexes. But you can show that serum or plasma from rheumatoid arthritis patients does induce inflammation in these mice, whereas serum from a normal individuals does not. There's just looking at arthritis in a mouse. So immune complexes containing citrullinated fibrinogen can be used to show that you can get TNF with immune complexes, and this is a citrullinated fibrinogen or a citrullinated fibrinogen immune complex where they've got anti-citrullinated antibodies, and you can show that you get very good production by human macrophages if you add these immune complexes. So at least, I'm building the argument that the anti-citrullinated antibodies actually, there's reason to suspect that they're acting like immune complexes and they are producing anti-TNF, and I think this is probably the reason why rheumatoid arthritis is such a symmetric disease. This is in part an immune complex disease. It's not like psoriatic arthritis where there's really no evidence of immune complexes. There's no evidence of autoantibodies. So this is an important component of the disease. What's interesting is that you can actually show that these anti-citrullinated antibodies can induce changes in the bone. That periarticular osteopenia that you see so early is actually probably mediated by these anti-citrulline antibodies. And this is from George Schett's group, where they were looking in humans, where they could see that these fenestrations where you can see these little holes on the micro CT of the MCP joints were present in patients with rheumatoid arthritis that were ACPA positive, and they also had thinning of the cortex. What's interesting is that this actually occurs before there's any evidence of synovitis. So this is people who are ACPA positive but haven't been diagnosed as rheumatoid arthritis. They still have these kinds of changes. And what they showed was that and this was mostly in tissue culture and in animal models, is that the anti-citrullinated antibodies would actually act on the osteoclasts, there are targets. There are citrullinated proteins in the osteoclasts or produced by the osteoclasts which can form immune complexes, and then the osteoclasts become activated. So here's just showing their idea that you have these plasma cells that are producing ACPA. This is sort of the early preclinical autoimmunity, but then you have anti-TNF. These ACPA antibodies actually acting on the osteoclast precursors and the osteoclasts so that they are making TNF, and that actually pushes them towards osteoclast differentiation. So there's a preclinical time where the ACPA is causing these fenestrations and the thinning of the cortex, and you're seeing that potentially on your radiographs as periarticular osteopenia, but really you need a micro CT to see this. And then you get the overt clinical disease, and then eventually you get all the erosions that we know of. So anti-TNF, one of the things that we've learned about it since 20 years ago is that it has a major, we have all this information about osteoimmunology, and TNF has a major effect on osteoclast differentiation, as George Shett was showing. And this is showing some of the pathways. The activation of NF-kappa B is a big part of that. The other effect that the TNFs have is that they actually inhibit the osteoblasts. So you've got, and this is showing all the different, this is showing a TNF actually working through the SMADs and through MAP kinases to block osteoblast differentiation. So you've got things working both ways. You've got increased breakdown of bone, and you've got poor repair of bone, all potentially due to anti-TNF. So this is our current model. Of course, is that we also have a big component of type 4 hypersensitivity in rheumatoid arthritis. This is where the T cells come into play. And really, it's the cells that are probably most important in terms of the bone and erosions are the Th17 cells, because they are a major producer of rank ligand, and they also produce IL-17, which induces synovial fibroblasts to produce rank ligand. And it's rank ligand that is key for the induction of osteoclasts. Th1 cells really can't do this. Th1 cells, which are making gamma interferon will block osteoclast differentiation. So that just having Th1 cells turned out to be not the best way to cause erosions in bone. So now, it is interesting that anti-TNF and production of IL-17 are linked. This is a very interesting, or I thought it was a really interesting paper, where people looked at if you treat people with an anti-TNF, what can you learn about the people who fail, right? So you've got a group of patients over here who had a moderate to good response, and you have over here some non-responders, and this is what's happening to things like Th17, IL-17 levels, IL-6 levels, IL-21 levels, IL-23 levels, TNF levels. And what you find is that there's a pretty dramatic increase from baseline in the number of Th17 cells and in the serum levels of IL-17 in the people who fail an anti-TNF. Going back to mice, you can show that you can take a mouse that lacks TNF receptor 1, this is P55 TNF receptor, and if you take those mice and you do collagen-induced arthritis, what you find is that the IL-17 production in the wild-type mice is down here, and when you have this blockade or this absence of TNF receptor 1, you get a tremendous increase in the amount of IL-17 produced. And this is, if you stimulate those cells from those animals with collagen-induced arthritis with an anti-CD3, you can see a similar thing. The other thing, though, that TNF is doing, there was that old study by Maney and where they showed that if you could label cells in the people that were being treated with infliximab you could show that the leukocytes don't home to synovium as well. That's also true for T cells. And I mean, I don't know that that's been shown in people, but in these mice, what they could show is that, you know, if you took a mouse and treated them with anti-TNF, a mouse where they had collagen-induced arthritis, they treated them with anti-TNF, they had this marked increase in the Th17 cells in the lymph node. But then, because anti-TNF actually blocks migration to the joint, you didn't get nearly as much of those, many of those cells into the joint itself. So you can see there's sort of there's a two-way effect of a TNF on the T cell part of this joint inflammation. On the one hand, it may promote the generation of Th17 cells, but on the other hand, it might prevent their migrating to the joint. So what wins may depend on a lot of things that we don't quite understand yet. Another aspect of this is that you know, you have cells that are Th1 and you have cells that are Th17 and you have Th17 cells that now look a lot like Th1 cells. So this marker CD161 is a marker for a variety of cells. It's present on Th17 cells and their precursors, but it's not on Th1 cells. And so if you look at peripheral blood cells from a human being, and you look at whether those cells are making IL-17 or gamma interferon, you find that there's some cells that just make IL-17, some cells that just make gamma interferon, but you got a whole bunch of cells that make both, and they are these CD21 positive cells. So these are Th17 cells that have sort of evolved into actually making both IL-17 and gamma interferon. And this is showing this in a diagram. If you have a naive cell, it can become one of these Th17 cells if you've got the right cytokines, or precursor cells if you get the right cytokines. Then it can become a full-blown Th17 cells. But it can change, and it can become a sort of a mixture of Th17, Th1 cells, or one that's just making gamma interferon. If you look at the joint of a RA patient, this is peripheral blood and this is synovial fluid. What you can find is that, you know, there are Th1 cells in both places. There are Th17 cells in both places, but, you know, there's a lot more of these ex-Th17 cells that are making both IL-17 and gamma interferon in the synovial fluid. If you look at the cytokines that these cells make, the Th1 cells make a lot of gamma interferon. They don't make IL-17. The Th17 cells are sort of the converse of that. But the ex-Th17 cells make the gamma interferon, they make IL-17, they make GM-CSF, and they make a lot of TNF. Okay? So you've got a problem here in the sense that although you can find some patients where just blocking one cytokine does the job, there are a lot of patients where actually giving the anti-TNF will promote the production of Th17 cells and IL-17, which will sort of bypass this blockade of TNF. So the one proposal is that you should be blocking both. And so there is a dual function antibody. It's got one set of variable regions that bind to IL-17, another set of variable regions that bind to TNF, and this has actually been in clinical trials in PSA. One last thing that TNF does, you know, it's sort of interesting that it has such a big effect on inflammation, and how does it block all of these different inflammatory mediators. Well, one of the things that TNF does, and this is actually common with IL-6 as well, is that they are very potent at blocking T regulatory cells. Okay, so if you block TNF or if you block IL-6, you promote the function of the T regulatory cells, and of course they have the potential for blocking a lot of different cytokines. So how much of the beneficial effect of anti-TNF blockade is actually due to this promotion of these regulatory T cells is not clear, but you can show that it really does occur. If you look at phosphorylation of FOXP3, and this is before and after patients are treated with an anti-TNF, you can see in the controls here. Let's see. This is showing the kind of cell that is present. You have, this would be the Th1 cells. This would be the Th17 cells. You can show that you actually have an increase in both Th17 and Th1 cells here, and they go down after you treat with anti-TNF. Oh shoot, I think I deleted this. The next slide shows that at the same time you get rid of this phosphorylation, or you get recovery of phosphorylation of FOXP3. So the TNF induces a phosphatase that dephosphorylates FOXP3, and that prevents it from going to the nucleus and having its effect as a transcription factor. So you've got FOXP3 protein produced, but it's not active. And they showed that in this same group of patients, you reverse that dephosphorylation of FOXP3, and you downregulated that phosphatase. So one last slide. There was an interest about pain, and so this is sort of an interesting study. It was in PNAS, Proceedings of the National Academy of Science. I have had patients who've gotten one shot of an anti-TNF, and they call me up the next day and said, man, I'm all better. Thank you so much. It's like, right, sure. I don't think that happens. But so this is functional MRI, and so this actually shows you where I think this was looking at oxygen metabolism. You can also look at glucose metabolism, but you can get an idea of what areas of the brain are active. And so this is looking at patients, day one when they started an anti-TNF, and then over 42 days, and actually day 0 is when they started. Day 1 is the day after they started, and this is looking at their pain scores. Visual analog pain scores are DAS-28, swollen joints, tender joints, and they compared, if they did a squeeze their joint, and they claim that they had a very consistent way of doing this, versus if they just had them tap their finger, okay, so that they would have sort of the same hand stimulated but in a different way, and they looked at the size of the area that is activated. So both of those will activate brain cells, because you have to have neurons for feeling pain or for moving the finger. But what happens, even within 1 day of getting an anti-TNF, the activation of the brain when you squeeze the hand went down fairly dramatically. Okay, so this may be the objective way of looking at pain to get your medications approved. You just simply have to do a functional MRI on all those patients and show that they don't have so much pain. Okay, thank you.